যাই সামনে যাই স্যার Rahim. Assalamu alaikum and very good morning. Me, Dr. Kamrun Nahar, Register, Department of Ops and Guiding. Honorable Chairperson, Honorable Director Sir, all professors, senior and junior colleagues, and my beloved intern. Welcome you all to today's weekly clinical meeting on different approaches of intrauterine fetal death management. Today's our chairperson, Professor Jinatun Madam, Professor of Unit 2, and resource person, Professor Shilashin Madam, Professor and Head of the Department of Ops and Gyne, and Professor Taiba Kandhin Mirza Madam, Professor of Unit 3, and today's our speakers are Dr. Nafisa Sultana Shathi, Assistant Register Unit 1, and Dr. Farhana Yasmin, Assistant Register Unit 2, and Dr. Mohsina Mahbub Mou, Assistant Register Unit 3. Now I am requesting our chairperson madam with resource person come up to the dais and conduct the rest of the session. Thank you.
Honorable Director, CBMCB, respected teachers, my dear colleagues, and my beloved intern, Assalamu alaikum. Welcome you all to this clinical meeting organized by Department of Obstetrics and Gynecology. And thank you everybody for being present here. We are very much delighted and excited to listen in the field of obstetrics and gynecology with us. And our speakers are, we have three speakers, Dr. Nafisa Sultana Shathi, Assistant Registrar, Unit 1, and she completed her MS in the last year, July. And second speaker, Dr. Farhana Yasmin, she is examining FCPS Part 2, and Dr. Mohsina Mahbuba Mou, she is also examining Part 2 FCPS. Now I would like to invite Dr. Nafisa Sultana Shathi, Dr. Farhana Yasmin, and Dr. Mahbuba Mou for their presentation. Please do come.
Assalamu alaikum. With kind permission of my chair, I, Dr. Nafisa Sultana Shathi, would like to present the first case. Mrs. Moshome, 20 years, primary gravida, normotensive, non-diabetic, housewife, hailing from Trishul Mymensingh, admitted in our hospital with the complaints of pregnancy for 32 weeks and less fetal movements for 6 hours. She was not in regular antenatal checkup, but her antenatal period was uneventful. Her expected date of delivery was 15 September 2024. She was fully immunized as per EPI schedule. She did not have any drug history. On general examination, she was anxious but cooperative, mildly anemic. BMI was 21.6 kg per meter square. Her blood pressure was 110 by 70 millimeter of mercury. Pulse was 70 beats per minute and temperature was 98.6 degree Fahrenheit. Per abdominal examination, symphysiofundal height was 28 weeks size, which does not correspond to her gestational age. Her fetus was in longitudinal lie and cephalic presentation. Fetal movements and fetal heart sounds were absent. Per vaginal examination, vulva and perineum looked apparently healthy. Cervical was closed. No abnormal discharge. Other systemic examinations were normal. Based on clinical findings, intrauterine fetal device was suspected, which was confirmed by doing ultrasonography of pregnancy profile. On further investigations, her blood group was A positive. Bleeding time, clotting time, and prothrombin time were within normal limits. Hemoglobin percentage was 11 gram per deciliter. Other routine investigations were also normal. After diagnosis, the patient and her family were provided with comprehensive counseling, including emotional support and informed about diagnosis and available options for delivery. Based on gestational age and clinical situation, decision was taken to proceed with termination of pregnancy by medical induction of labor by mifepristone and misoprostol. A dead male fetus weighing 1.5 kg was delivered on 4th August 2024 at 7 am after taking 1 dose of mifepristone and 4 doses of misoprostol. After keeping in observation for 24 hours, the patient was discharged with advice on 5th August 2024. Thank you. Now I request Dr. Farhana Yasmin to present her second case.
Nafisa Sultana, me Dr. Farhana Yasmin, Assistant Registrar in Ops and Gyne Department. Now with the permission of the chairperson, I would like to present my second case. Miss Jahanara Khatun, 32 years old, para 2+0, third gravida, hypertensive, non-diabetic and non-smoker housewife, hailing from Talukder, Mymensingh. Got admitted on Obedient Department of CBMCB on 3rd July 2024 at 7 am with a complaint of pregnancy for 30 weeks and absent fetal movement for 6 hours. She was not in regular antenatal checkup, but her antenatal period was uneventful. She had no history of trauma and did not have history of taking any significant drugs. She was immunized according to EPI schedule. On examination, she was anxious but cooperative, mildly anemic. BMI was 23.6 kg per meter square. Blood pressure was 140 by 100 millimeter of mercury and pulse was 92 beats per minute. Respiratory rate 20 breaths per minute and temperature was 98 degree Fahrenheit. Bedside heat coagulation test was negative. There was a scar mark in the lower abdomen for previous cesarean section. Her symphysis fundal height was 30 weeks, which corresponds for her gestational age. The fetus was in longitudinal line with cephalic presentation, but there was no fetal movement and fetal heart sound. On her vaginal examination showed apparently healthy vulva and perineum. No abnormal discharge was present and cervical was closed. Ultrasonography was done, which showed 30 weeks of gestation with intrauterine fetal death. Her bleeding time, clotting time, platelet count, prothrombin time, and other routine investigations were within normal limits. So, she was diagnosed as a case of third gravida, 30 weeks of pregnancy with intrauterine fetal death with gestational hypertension with previous 1 cesarean section. The patient and her family underwent counseling, including emotional support, and were explained about the treatment options. Based on gestational age and previous history of 1 cesarean section, we decided to terminate the pregnancy by transcervical balloon catheter. Termination of pregnancy by induction of labor by introduction of transcervical balloon catheter was done on 10th July 2024 and a dead fetus weighing 700 grams delivered spontaneously on 11 July 2024. The patient was discharged on 13 July 2024 with advice for follow-up. Now I request Dr. Mohsina Mahmoud to come on the dais and continue the next presentation. Thank you.
Assalamu alaikum. I am Dr. Mohsina Mahmoud. With the permission of the chairperson, I would like to present my case. Mrs. Janatul Mawa, 28 years old, second gravida, para 1+0, normotensive, non-diabetic, housewife, hailing from Tarakanda, Mymensingh, got admitted in OB/GYN department of CBMCB with the complaints of pregnancy for 30 weeks and absent fetal movement for 1 day. She was in regular antenatal checkup and her antenatal period was uneventful. She had no history of trauma. She used to take tablet Montelukast due to asthma. She was immunized as per EPI schedule. On examination, she was anxious but cooperative, mildly anemic. Her BMI was 20.3 kg per meter square. Blood pressure was 110/80 mm of mercury. Pulse was 110 beat per minute and respiratory rate 18 breaths per minute. There was a transverse scar mark in lower abdomen for previous cesarean section. Her symphysephadal height was 28 weeks of size, which corresponds for her gestational age. Fetal heart was absent. There was tenderness on lower quadrant. No abnormalities were found on vaginal examination. Ultrasonography was done, which showed 30 weeks of gestation with intrauterine fetal death. Her bleeding time, clotting time, platelet count, prothrombin time, and other routine investigations were within normal limits. So she was diagnosed as a case of second gravida, 30 weeks of pregnancy with intrauterine fetal death, with previous one cesarean section with scar tenderness with asthma. The patient and her family were notified and counseled. They were explained about the treatment option. So, decision was taken to terminate the pregnancy by transcervical balloon catheter on 3rd September 2024. Before doing balloon catheter, patient also received single dose of tablet mifepristone. We waited for next 2 days, but there was no response. Re-evaluation was done, but service was not favorable. So, decision was taken for undergoing cesarean section. A dead male fetus about 1.5 kg was delivered. She was managed and discharged on 5th day of cesarean with proper advice. Following delivery, all patients' pubertal period was normal. So, they were discharged duly with cabergoline 0.5 mg orally for milk suppression. This was the picture of transcervical balloon catheter. What is intrauterine fetal death? Intrauterine fetal death embraces all the fetal deaths weighing 500 grams or more occurring both during pregnancy or during labor. For practical purpose, antepartum death occurring beyond the period of viability is termed as intrauterine death. Causes of intrauterine fetal death. It may be idiopathic, maternal, fetal, placental or iatrogenic. Among them, fetal cause is most common. In case of maternal cause, it may be due to hypertensive disorder, diabetes, maternal infection, hyperpyresia, anticoagulate antibody syndrome, thrombophilia, abnormal labor, postpartum pregnancy, systemic lupus erythematosus. In case of fetal cause, it may be due to chromosomal abnormalities, major structural anomalies, infection, Rh incompatibility, non-immunohydrops, and growth restriction. In case of placental cause, it may be due to intrapartum hemorrhage, cord accident, twin transmission syndrome, and placental insufficiency. In case of iatrogenic cause, it may be due to external cephalic version and drugs. Complication of intrauterine fetal death. Psychological upset of the patient, manifestation of uterine infection, falling fibrinogen level leading to disseminated intravascular coagulation. Take home message. Pre-conceptional counseling, proper antenatal and intranatal checkup. After diagnosis of intrauterine fetal death patient, counsel her with tender loving care. Caesarean must be done with indication. Uterine scar repair meticulously in a scientific way. Thank you.